The triangle represents the humerus superimposed onto the ulna. Now, as you can see, the red line on the left on the humerus and the supinated crest has ruptured. This allows the ulna. It allows the radial head to supinate pathologically. You compare this diagram to the diagram on top where it's normal. All right. So the radial head has now dropped up behind the humerus, and subsequently the ulna also external rotate. If it clears the trochlea enough, you will get a simple dislocation. If it doesn't clear enough, you will get a tip of the coronoid impinging against the trochlea and getting a tip of coronoid fracture, the so-called type 1. So can you see how the tip of the coronoid is overlapping the triangle? Right. Now if you go to the second diagram, this is the classic posterior lateral terrible triad. Again, in this, the collateral is damaged and the medial collateral is also damaged. This allows significant external supination and external rotation. As this happens, more of the medial facet has been brought into contact with the trochlea, causing the anterior medial facet and the tip fracture. The amount of external rotation will dictate how much of the type 2 injuries that you will get, whether it's A, B, or C. It depends on how much of the ulna has external rotate relative to the humerus. Now, if you look at the diagram on the right, this is the model for the varus posterior medial. In this injury, first, the ulnar collateral, the lateral collateral ligaments rupture on the red line on the top. It allows the whole arm to move into varus, and for the coronoid to get contact with the trochlea. As this happens, it allows the coronoid to internal rotate, bringing more of the body to be in contact with the trochlea. As you can see on the diagram, there's more coronoid overlapping the triangle. So depends on the amount of injuries. The more ligament you damage, the more it allows the whole ulna to internal rotate. Then it might clear the bone without causing any fracture. If it doesn't, this varus posterior medial injury typically cause a basal coracoid or body of the coracoid fracture. So normally the muscles and the tendons are less injured than the ligament. And the reason for this is because the ligament has a lower Young's modulus, the collagen fibers are less parallelly aligned, and the muscles with a larger surface area act as a shock absorber. The ligament can rupture as an avulsion or avulsion fracture with a flake from its origin, or mid-substance rupture. Most of the time, the LCL and LUCL sustain a avulsion fracture or avulsion from the humeral origin. So if you look at the picture from A to E, this is the mechanism for a simple or posterolateral varus dislocation, whereas from F to J as a posterior medial dislocation. As you look at F, you can see that the lateral collateral ligament goes first. As the lateral collateral ligament goes first, and you impart the varus force, this allows the radial head to move away from the capitulum, so saving the radial head. Compared to A, again, the initial event is either the medial collateral or the lateral collateral, but in both cases, the lateral collaterals are the ligament that's damaged. And this is important to recognize. Whatever elbow fracture dislocation, lateral collateral ligament is most likely get damaged. Again, we can see how people fall, right? If you look at this MMA fighter on the top left, she fell down with a supinated hand and she dislocated her elbow in a typical posterior lateral valgus instability. Whereas the skateboarder on the top, it fell with the arm pronated, so it has a varus posterior medial instability. So is the guy on the bottom as well. And most of the time, people who knows how to fall with a posterior medial type of mechanism. So just to summarize again, in a varus posterior medial instability or dislocation, we often get a coronoid body or basal fracture. very rarely, if the ligaments is damaged enough, you get only the tip. You will definitely get the MCL rupture and the LCL rupture. The LUCL sometimes doesn't get ruptured because because the arm just move into varus. So the LUCL doesn't get, the LUCL works to protect from a posterolateral injuries. So if you see a low body basal fracture with no radial head fracture, it's most likely a posterior medial instability. Okay. With regards to the medial collateral ligament complex, it's either the anterior or the posterior bundle. It depends on the position of the elbow when you fall. If the elbow is more flexed, the posterior bundle will get damaged more. If the elbow is more extended, the anterior bundle will get damaged more. The coronoid, as we say, is often low body or basal fracture. The LCL is definitely ruptured in this, but LUCL may get spared. Whereas in a valgus posterolateral instability, we get our typical terrible triad. In this, the radial head will get fractured. Otherwise, it will be a simple dislocation. The LUCL has to go first to allow the radial head to drop back in a supinated position. And as the ulnar external rotate, it clears the trochlea, and only the tip of the coronoid get damaged, or not at all. And as Hodgkin has shown, MCL often get involved early on in this mechanism of injury. So by looking at the involvement of radial head in a dislocated radial head and the coronoid, it allows us to predict whether this is a varus posterior medial or valgus posterolateral injury. So we can plan our surgical approach according to the fracture and the ruptured ligament and get our plan B and C. Although we treat the fracture, it doesn't mean that we need to operate on the patient. Sometimes an EUA and a plaster immobilization, a conservative treatment, is also a form of treatment. Now, the surgical strategy will be repair, reconstruct, fix, or replace. And if you really can't do that, then you can do an X-fix or even an in-fix. Just to recap, for the fellows, for the residents, if you look at these pictures on the screen, what sort of injury do you think this is? On A. Should we ask? I don't remember that many people, so I only remember Don Cole so far. So Don, are you there? No? Don, you're on mute.
You can also ask Bin Hao. Bin Hao is
Bin
our
Hao?
resident. Yeah.
Bin Hao, what do you think? Okay, never mind. I think the reception is not very good. So as you can see on A, the radial head moves away from the capitulum. This means that LCL is ruptured, right? And as you can see, the ulna starts moving to varus. So this is a varus posterior medial instability. And you can see majority of the coronoid is still in contact with the trochlea, and you'll get a body or a base fracture in this.
Morning, Fifi.
Okay. Now, this is an interesting biomechanical study. This group of researchers shows that when you have an intact coronoid and intact ligaments, the distribution of pressure across the coronoid is very even. So blue color means low pressure, and red color means hot color means high pressure. If you lose the anterior medial facet of the coronoid, of course, there's less surface area to share the pressure, so it's higher. But as you cut the LCL, you can see red areas on the third pictures down the screen. There's significantly increased pressure on a particular spot, and this will increase your medial OA early on. And if you go to the bottom, if you lose the posterior bundle of the MCL as well, the rim of the coronoid will undergo significant increased pressure. So this shows that the importance of dealing with the coronoid, the LCL, and the posterior bundle of the MCL when we deal with this kind of injury. So this is a patient who have a fracture dislocation of the radial head. the tip of the coronoid, so a typical posterolateral terrible type of injury. The surgeon has elected to replace the radial head. You can see an endo button on the dorsal surface of the ulna. This is used as a suture button to repair the tip of the coronoid onto the ulna with a suture. And the endo button on the top of the capitulum again is a repair of the ligament. Now, as you can see, as the patient flexes, the olecranon moves away from the trochlea. And this is because the posterior bundle of the MCL has not been repaired, and it allows the ulna to drop away. So we have to screen the elbow at the end of the operation to make sure that the MCL, particularly the posterior bundle, is not damaged or incompetent rather. So just to recap quickly for the residents, the location of the LCL. The LCL comes from the center of the capitulum and goes to the supinator crest. It inserts onto just distal to the annular ligament, and it blends with the annular ligament. Anteriorly, there's the LCL complex proper. Now for the MCL, you can see where the brachialis is. The brachialis actually inserts a bit further down from the coronoid tip. And next to the coronoid tip, there's a ridge. This is the sublime tubercle. And just below the sublime tubercle, this is where the MCL attaches itself, the anterior bundle. And this is the reason why O'Driscoll's classifications particularly look at the sublime tubercle, because the sublime tubercle is where the ligament attached. If you look at the diagram on the right, the posterior bundle attached to the proximal end of the ulna, and there's no surprise that this ligament is very important to hoist the ulna up into the trochlea. And if this is neglected, then we will have some residual subluxation and increased pressure on the trochlear coracoid interface, like we see on the biomechanical study. So this is sorry, let's go back. So this is the elbow stabilizers that we often see in a textbook. And we can look at them in three different planes. In the sagittal plane is the ulnar humeral articulations. The coronoid and the olecranon traps the distal humerus in place, and it stops the sagittal plane translocation. Whereas in the coronal and axial plane, you have the posterior medial instability and the posterior lateral instability that we discussed earlier. Just to bear in mind again, if the Dorp sign persists, posterior bundle of the MCL needs restoration. And this is a diagram shown by Bob Hotchkiss to see how the elbow, the forearm move relative to the distal humerus because of the muscle pull. Finally, we'll just come to the surgical approach, then we'll have a break. Now, I would recommend the Journal of Clinical Orthopedics and Trauma, this article from Professor Ayer's unit in King's College, London. Professor Ayer is actually the the associate editor for this journal. And this is a very useful article for the residents to read to prepare for the exams. We can enter the elbow via different routes. The most common way for the lateral side is either our coccus, a Kaplan's, or our EDC split. So the coccus approach, we find the anconeus, and that's normally a sliver of fat that separate the anconeus from the rest of the extensor tendon. The only problem with the coccus approach is that it's directly over the LUCL. Sometimes you can damage the LUCL if it hasn't been damaged, but if it's already damaged, it actually gives you directly where the LUCL is, and you can repair it easily. Now, we have to be cautious about the posterior interosseous nerve when we use this approach, because it comes up from the supinator muscle, about a patient's 3 fingers breadth distal to the radial head. One of the way that I use to protect the pin nerve during this approach is to release the humeral head of the supinator, and this allows me to retract the supinator muscles vollarly and distally, and this will bring the nerve with the muscles together a bit more distal, and it gives you often 1 or 2 centimeters extra to put your radial head plate. Whereas with the EDC approach, you can go in between the ECU tendon, ECU and EDC interval, or mid EDC. The problem with this anterior approach is that the posterior anterior osseous nerve is anterior to the capsule. And as a way to protect this, if you go to the humeral ridge and release the ridge and the capsule all together, you bring the brachioradialis and the capsules and flip it forward. This will allow us to move the pain nerve away from the danger zone. Of course, we cannot retract too much, but it will allow us to move all the way across to the at least 2/3 of the radial head. However, with this anterior approach, it's very difficult to reach the supinated crest if reconstruction is required. But not to be worried, because most of the time the LUCL is avulsed from the humerus, so you don't have to go to the supinated crest. With this approach, you'll be able to see more of the radial head, and you'll be able to repair the LUCL. And with the worst case scenario, you can just make another window in the coccals interval with the same skin incision. This is the picture showing a two-window approach, so above and below. So, and I want to draw your attention to the white arrows on the pictures on the left. You can see the posterior interosseous nerve sitting intimately just in front of the capsule. Again, this is demonstrated on the right. Let's go to the next diagram. Now, on the medial side, there are three commonly used approaches depending on the level of injuries. And now our choice of approach depends on the fracture position. So for a posterior medial fracture, we need to go to the base. So we need to use a more dorsal approach. So the more dorsal approach could be an ECU split. You find the ulnar nerve, as we can see on the diagram on the left. You follow it down to the elbow. Beware of where the black arrow is. This is the cutaneous nerve. So we want to avoid damaging this, otherwise patient will get a painful neuroma. So with this, you can release the FCU and lift the FCU with the flexor tendon anteriorly. However, there's a limitation to this approach because one of the motor branch to the FCU goes anteriorly. And so this will limit the movements of the muscles. Often this branch gets sacrificed. Alternatively, you can go all the way to the bottom, lift the FCU and the nerve all together to the top. This is called the Taylor shunt. And finally, number one, the red line number one is the Hotchkiss approach, the famous Hotchkiss approach, which we use to go over the top. And this approach is only useful for the top of the, it's only useful when we have a fracture of the body or the anterior medial facets, because it will be difficult to reach the bottom. So this is the diagram. The Hotchkiss approach on the top left, A, you split between the FCU and the FDS, and you leave the entire FDS off the half of the FDS off the humeral ridge. This way, you will be able to see the MCL and the coronal, and you can see the brachialis on the front on diagram B. Now, if you use the Taylor-Shelms approach, you can lift the entire nerve and the muscle up, but this will limit how far you can go anteriorly because the nerve is trapped at the back. Often you have to do a anterior transposition of the nerve. And these are the reference for you to look at if you want to look at the approaches to the elbow. Now finally, there's another easy approach for you to go to both sides easily. So you can use a posterior approach, and this approach is called the posterior utility approach. This approach is quite easy. Essentially, you go through the back, and then you split between the lateral 1/3 of the tricep tendon and the aponeurosis. You bring it down onto the interval between anconius and the dorsal ulnar, and you lift the anconius upwards. The danger of this is that if you extend your incision too proximally, you will damage the nerve to the anconius, because the nerve to the anconius comes from the radial nerve within the muscle belly of the lateral head. So with this approach, you have to release the LUCL from the supinated crest to sublux the elbow. Sometimes in this approach, the LUCL is already a walls from the humerus, so you can sublux it easily. You don't have to release it from the supinator crest. Whatever release that you need to do, in the end, you just simply repair with an anchor. And if you go to the medial side, simply develop a skin flap on the medial side. These are the useful resources for you to look at. The Cambridge Orthopedics by Lee Van Rensburg has a lot of approaches, and it discusses about different approaches to get to the elbow. It's very useful for your FRCS exam and also for your day-to-day practice. And finally, Anand has edited special editions on the Journal of Clinical Orthopedics and Trauma, and there's a special elbow editions. I will encourage you to have a look at these editions, and you will see different management of the elbow conditions by world experts. And the very last thing that I want to touch on before we have a break is to look at the post-op rehab. One important point to raise here is that when you put your shoulder in abduction, it will cause a various stress from gravity. And this also, and if you carry a weight in your hand, it's even worse because the lateral tensile force will put a lot of strain on the LUCL, and it will cause a compression force on the medial side. So after we do elbow surgery, the most important thing we want to do is to avoid shoulder abduction, to avoid the various stress tests. We can ask the patients to do overhead anti-gravity, passive or active assisted range of motion. What is also important, I often ask the patient to do immediately after surgery, is to do an isometric bicep contraction. This will help to bring the ulna into the trochlea. And finally, ideally, after we do any elbow fixations, we try not to use a plaster. We want to mobilize the patient as soon as possible. Sometimes it's not always possible because the bones are quite soft, ankles doesn't hold. So you might have to use the plaster to immobilize for a couple of weeks or even to rest the skin. But try not to immobilize more than 3 to 4 weeks. Ideally, no immobilization is recommended. So this brings us to the conclusion of the first session, and we will have a 10 minutes break before we go to the case-based discussion. Before we go to the break, do you guys have any question or anything that Anand and Puya wants to add on?
No, I think that's fine. Actually, you have very comprehensive presentation of the elbow instability. Yeah, no, I think that's perfect.
Yeah, I agree. That was very good.
Any questions from the audience? Anything that's unclear that you want to ask? Okay, great. We'll have a 10 minutes break. We will probably have to draw this session to the end a bit earlier because it's quite late over in the West, but we'll try to get through as many cases as we can. Okay, I'll see you in 10 minutes.
Quen.
Yes.
You better let Don Cole and I think I spotted somebody else. Gideon is also in the audience, so you better prime them. And Brian is also.
Okay, Ken.
Hey Brian, can you hear us?
Yes, Prof.
Okay. So hey Don, I think Don says he's on call. So Don, are you available?
No.
Looks like it's yeah. So Brian, stay in touch. We may need to call you. Let me see. Winston.
Yes, Prof. Yep.
Can. I think Bin Hao is out. Is it Bin Hao or Gideon?
I'm here, Prof.
Oh, you're here. Just now we
Yeah.
call you, but okay, Can. Yeah. So Quen may call you guys to solve the cases.
By the way, these presentations is available for you guys to keep if you want to use it for revision. I'll give the copy to Jane. And if you want to have a read on the Journal of Clinical Orthopedics and Trauma and Orthopedics and the special elbow edition, I can try to speak to Anand to see if he will grant some special access for that for you guys.
Yeah, that sounds good.
Yeah,
Okay.
I can send the link and the whole, the digital copy of
Thanks.
the whole
Thanks.
issue. Yeah.
All right. Well, let's take a 10 minutes break then.
Yeah. Morning, Heng An. Long time no see.
That's right. Morning. How are you?
Yeah, so 1 a.m. in London.
That's right. Yeah, it's almost 1:15 actually, and it's a very interesting experience to
Yeah.
participate in the meeting at this time. And
Well,
I put my alarm on to woke up, but then again fell asleep. So it was good that Kion actually called me. Otherwise, I would have missed it.
yes, that's why I told him that about 15 minutes to 20 minutes before
Yeah,
to better get you guys into the Zoom.
yeah,
Sometimes the technical glitches can be daunting.
absolutely, absolutely. Yeah, yeah, yeah. That's right. So I mean, and Kion and I have a very long association, and I really enjoyed his company. We used to go to Mayo Elbow Coast together, and then we we enjoyed our time there. And I mean, whatever. I mean, we have lost him here, so our loss is your gain.
Yeah,
You.
indeed, indeed. Yeah, but he belongs to Asia. You can see he belongs to Asia.
Yeah, that.
Okay, I think we'll let everybody have some rest.
Okay, all right. So we'll come back in sort of 5 to 10 minutes. Yeah.
Morning, Hamid. Morning, Koksan. Hello.
Just take a photo.
Well, guys, for the time purposes, I'm aware that it's quite late over there. So can we, if you don't mind, we shall start with the first case. Let me just move the camera across to Wing. So can we put something in the share screen? Guys, can you see the screen? Yeah.
Yes, we can see the screen.
Okay. So this is a 31 years old male, and he has fell on an outstretched hand. And you can see this is the picture of what happened. Glennis, Glennis, are you there? Hi, Glennis. Have we unmuted everyone, or let's unmute everyone? Allow participant to unmute themselves. Yeah, you should be able to unmute yourself. Okay, never mind. Let's start with something simple. Brian, are you there?
Yep. Hi, sir.
What do you think about this?
Okay, so this is an AP and lateral radiograph of a patient's left elbow, demonstrating a posterior lateral dislocation. I can also see that the radial head appears to be fractured.
Yes.
Appears to be more than 2 or 3 pieces, but I'd like to get I'd like to better evaluate this later on with a CT scan. So
Sure.
I don't see any other fractures here. I can't really see the coronoid. The coronoid tip generally looks to be intact. So to manage this patient, first do it by ATLS principles, assuming this is isolated injury. Then I'd like to look for the skin, check the neurovascular status, in particular the radial and the ulnar nerve, as well as the median nerve, and also get a full-length X-rays of the forearm, as well as the humerus. Assuming, yeah, sorry.
Yeah, no, well done.
Oh, okay.
We don't have a CT. Unfortunately, we're now in England and it's really bad. They don't have money in NHS. But based on the mechanism of injuries that we have spoken earlier about, right? This is a radial head that drops backwards, right? So the radial head that drops backwards, that means the LUCL is gone. The LUCL is gone, the radial has dropped back down. So the ulna would have then external rotate to clear most of the coronoid. So at most, you will get a anterior medial facets or the tip of the coronoid fracture. Does that make sense?
Yes.
Yes. So even without the CT scan, you will know that okay, the radial head possibly in multiple fragment. With its age, we'll try our best to fix it. But if it's not fixable, then what else can we do about this? We'll have to prepare for replacement, right? So you get your replacement ready, you get a fixation ready, and then you think about the anterior medial facets. I may need to have a plate for the anterior medial facets. Okay, great. So let's see what we have done. Sorry, go back to the intro pictures. This is the time. Okay. Let's see what happens in the theater. So you can see the radial head fragment. It's actually sitting anterior medially. It's in multiple pieces, and the elbow is very unstable. And as you can see, the ulna has actually dropped down. And what does that tell you, Brian?
Like what you said, the ulnar drop.
Yeah, so the posterior
medial.
bundle of MCL is probably gone as well. Yeah. You can see it's very highly unstable. So we have fixed the radial head. I will show you the pictures of what we fixed the radial head with, and then we also repair the ligament. But you can see there's no metalwork there, and the radial head is already back together. Isn't that amazing? What do you think we have done with the radial head? And this is united nicely there. So if I can share my screen now, I'll show you what we have done. I'll find the picture first. So you can see here, we go into the lateral side. The radius is in multiple pieces. So we piece them back together with K wire, temporarily hold it together. There's an area of void in the center that we cannot replace. We cannot find it back. So we put some fibrin glue, the tissue glue that you use to fix nerve. And after that, we fix them with a smart nail from Conmat. This smart nail is a bioabsorbable material. It looks like plastics. And in 2 years' time, it will get absorbed by the body and it will disappear. So this elbow will be as good as a virgin elbow in 2 years' time. Okay. Right. Let's go to the next one. Yeah, the lady with the plate. Okay. This is lady with the plate, right? Yeah. Okay. Right. You're off the hook now, Brian. So shall we eeny, meeny, miny, mo, still trying don't go. It's not here, right?
I want to try
Gideon,
Winston.
Winston, are you here, Winston? Huh? We share with you, right? Winston, are you here? No. Gideon? Gideon, are you there, Gideon? Joseph? Hello, Joseph?
Yeah, I saw Joseph somewhere. Yeah.
Yes, morning, Mr.
Yeah,
Chin.
great.
Hey, man. Good morning. How are you?
Good, thank you. Yeah.
So this is a 19 years old lady with a radial hip fracture.
Right.
And this is the pictures. What do you
Yes,
think?
this is the epilateral radiographs of this patient's elbow. What I see is the radial head fracture, and he also appears to be a bit depressed on lateral view, and on the olecranon also appears to be, there's the drop sign that you mentioned, and on the AP view, it also appears to be in a valgus position,
Hmm.
and the joint space appears to be opening up. So I'll be concerned about the lateral sided injuries. LUCL is likely injured, and it is gone a circle to involve the medial side. So I'll be worried about any coronoid fracture, associated coronoid fracture as well, and also the medial sided injuries. Not sure if there's any small fragments. And
So
posterior.
how are you going to tackle this? So you suspected that there's a gross ligament instability. All the ligaments are
Yes.
gone and the radial head is no longer buttressing it, right? So you see the head,
Yes.
as you say, the radial head has been depressed down away from the capitulum. So it's
Yes.
no longer acting as a lateral buttress there.
Yes.
So what are your treatment strategy for this patient?
So treatment strategies, firstly, it'll be location-based, either in the A&E or in the ward. So in the A&E,
Oh no, so we're in theater now, you're surgeons. You're gonna
in theater.
offer this.
So in theater, preoperatively, would I have access to any CT scan or MRI, advanced imaging, or anything like that?
Oh, no, you just have brilliant lectures, so you know you can predict what's damaged. So
Okay.
what you know that you've got a piece of radial head that's got squashed down, right? And then
Yes,
you
that's
see that the whole ulna is disconnected from the humerus. So
Yes.
with these pictures, most of the ligaments, medial and laterals are all gone.
Yes.
So what's gone through your mind?
So going through my mind, I would intraoperatively either fix or replace the radial head depending on the extent of comminution intraoperatively, and also ligamentous reconstruction of all the torn ligaments and the medial and lateral aspect of the elbow.
Interesting. So you say reconstruction. Are you going to reconstruct or repair?
I'll
What
try
are
and
your thoughts?
repair it first. Try my
Mm.
best. I mean, still
Mm.
preserve the native ligaments and repair if possible. If not
Yeah.
possible, then I require the use of adjuncts like suture anchors and things like that.
But they're still repairing. If you're
Still,
going
still
to, you mentioned about
maybe
reconstructing. What are you
and
going to
lastly,
use for? Yeah.
probably allografts that can help to reconstruct.
So what sort of allograft will you be asking for?
In my mind, I think, is it possible for palmaris longus?
I think palmaris longus, but you can use the patient's self palmaris longus, right?
Yeah, autograph, yeah.
Do you know roughly how many percentage of people in the world does not have a palmaris longus?
About 10 to 20%.
Yeah, roughly about 30%, but it depends on the population. So all right. So the odds are you're likely to be able to find palmaris longus on this patient. Some
Okay.
patients have palmaris longus on one side, not on the other side. But
Mm.
yeah, okay, good. So let's show this just sort of the sequence of event. So as we move along, we can see the elbow just dislocates as highly unstable.
Mhm.
So first we elevate the head to try to create a buttress, but it is still unstable. Can you see the whole radius and ulna? It's just shifted radially in this picture, right? So the ligaments are not there. So we reconstructed the ligament on the lateral side, the LUCL, and then the medial side as well, and it's stable. So we stabilize the radial side first, the LUCL, but after the LUCL is still dislocated. So we check the wrist to make sure there's no other any asexual or any DIUJ injuries. There's no shortening, no piano key sign. It's still unstable. It still keep dropping down. So the lateral side is not enough, as we said earlier from the lectures. We have to go medial. So we go to the medial side, reconstruct the medial. If you look at this X-ray now, can you see there's two little radial? Can you see my cursor on the screen?
Yes.
Yes.
You can see the cursor is pointing to two little holes there. Yes. These are my transosseous tunnel that I use to pass a allograft or a synthetic ligament into the supinator crest and goes back to the capitulum. Now, the medial side actually doesn't need reconstruction. It just needs repairing. So we simply, as you say, put the anchoring and repair it. So this is before repair. This is after repair. So stable throughout range of motion. Valgus, whereas stress, it doesn't open up anymore. And this patient has near full range of motions after treatments. I've got a video of that. There you go. And you can see the two transosseous tunnel that I do there and there. Okay. Right. Let me show you the pictures here if I have them. So yeah. Let me share them. And this is a synthetic ligament that I've used. Can you see on the screen? So in is that the
Yeah.
okay, good. Right, as you can see here, can you see my cursor here again? There's two frets here. So this is the center of the capitulum. It goes in as a docking technique. So it docks into the capitulum and come out on the front and the back of the lateral humeral ridge. It goes down under the radial head and goes to the supinator crest, like so. So you've seen two strands of that. So the LCL and LUCL are reconstructed using a synthetic ligament. This is the BioBrace. Okay, right. Let's do one last one before we call it a day. Okay. So this again. No, go to the one that's totally broken with metal on this one. Once transport coming. This one, yes. Okay. Right. You're sharing, right? Okay. Good. Who else do we have left? Winston, are you here?
Yep. Hi,
Hey, man.
sorry. Yep.
Right. So this unfortunate lady is 79 years old, and she had a fall.
Oh, okay.
What do you see there?
Yeah, so I mean, this is the AP of the right elbow. I can see that there is a complex proximal ulnar fracture associated with a fracture of the radial head. So this ulnar fracture appears to be a transolecranon type of fracture, and it has a long sagittal split down the proximal ulnar. So assuming that this is an isolated injury, I would want to
Yeah,
That's
isolated
immobilized.
injuries. I agree. So
Yeah.
you know, if you're going to do this for the exams, right? So you know, normally they will just cut the chase. You know, all this standard stuff about whether you, ATLS, those doesn't score you any points. Not
Yep,
going to
so-
score you points. Let's go to the
Okay, so
let's go to this.
my initial management will be to first immobilize the patient and provide analgesia and spleen the patient, and then also want to check to make sure that all the nerves are intact and that this is a closed injury. And then my definitive management will be based on after my planning, which I will require a CT of the elbow.
Unfortunately, again, you are in England doing your exams, and they have this case come to you, or you're doing a fellowship there, and you learn how to live in third world country. Okay, let's share this screen quickly. Right. Remember this diagram that we talked about earlier? This classification?
Yep.
So, look at the classification. So you know that this humerus has a direct axial compression going through the coronoid, and you fracture the coronoid and split it. The coronoid is neither attached to the metaphysis or the olecranon. Does that make sense? The blue line. Can you see this? See the screen? The blue line. So this is how the mechanism of injury is. So there are three components there that you need to deal with. One is the combination between the olecranon and the metaphysis. And two is a coronoid, which gives you the stability. And finally, your olecranon piece, which gives you the extensor mechanisms. So all three of these has to be addressed in your strategy, right? Now, how do you get this line correctly? What approach are you going to use for this?
So in my approach for this, I will first start with a posterior approach to fix the proximal ulnar. And from there, I want to ensure
how are you going to fix the ulnar? It's comminuted, right?
Yep. So I want to restore the articular surface, restore the length. And
yes. How do you know the line is correct?
So there are a few ways you can use this proximal ulnar deviation.
Yes. You're getting to the right.
Yeah, so we want to compare to the contralateral, the PUDA. So we want to compare to the contralateral side.
Yeah. So be aware there's a slight proximal ulnar dorsal angulation, right? And the dorsal angulation varies. So what the value that we see in the literature does not apply. So the literature says that there was about 5 degrees of 3 to 5 degrees of dorsal angulation. We had a look in my previous hospital. There's a lot of black people and ethnic minorities and Indians. Our PUDA actually was anywhere from -1 to about 10 degrees. So there are a huge spectrum of different PUDA. You correctly pointed out that you want to look at the other side. So you might want to get a pre-op x-rays of the other side. Yeah. To know what the PUDA roughly is, then you have to contour your plates. Okay, that's one thing. What else do you think the ulnar has, apart from Puder?
The ulnar also has rotation.
Yes, correct. And what sort of rotation it is?
So that one we have to base. It's a. So I'm not too sure, but I mean
So
there's a rotation that
essentially,
to match.
yeah. So essentially, the olecranon tip and the coracoid tip doesn't line up. The coracoid tip is internal rotated by about 3 to 5 degrees again, and that's because the corona has to turn slightly medially to cover the spool of the trochlea. And this is just a developmental thing. So it's slightly rotated. Okay. And finally, very important point to be aware of, more than the Puda, for this kind of fracture that goes quite distal. The
Sorry.
ulnar,
Yep.
the ulnar also has a varus angulation, right? And
Okay.
it's roughly about 5 to 6 centimeters away from the tip of the olecranon.
Okay.
So when you put a straight plate, you might fix a bend bone into a straight plate and make it straight, and this may affect the length of the radial head reduction. All right, because if you straighten a bend bone, then you essentially lengthen it, then you create space on the radial side and cause laxity, right? So you have to be aware of the varus angulation as well. So the ulnar has three components: varus angulation, Puda, and internal rotation.
Yep. Okay.
Does that make sense?
Yep.
So if you want to read more about this, you can read on the anatomy section on Anand's special elbow edition. It talks about all this angulation. Okay, right. Now, so with this combination, how are you going to deal with that? There's too many lost bone in the middle. Is there any strategy that you can use?
Sorry, I didn't catch you again. So you said
So
that
there's a lot of combination in the metaphyseal area.
Yep.
How are you going to fix down how are you going to fix down the area where you have bone loss, and how are you going to fix the area where fix the coronoid down? So what plates will you ask for?
Oh, okay. So I mean, based on this, I want a proximal ulnar locking plate, and then I'll also want to stand by my plates for the coronoid in case that the coronoids are also fractured off.
Well, the
And then,
coronoid is fractured. Clearly, you can see there, right? The coronoid is a
yes,
separate fragment there.
yep, and also some radial head plates and the radial proximal radial head replacement.
Sure. So let's show you what we've done. So this is what we have done. We have used a hand plate to breach the metaphyseal area, and then we try to catch the coronoid fragment with a long screws. The coronoid fragment was actually too comminuted for us to put any buttress plate on it. So we just try to catch as many fragments as we can, as much of the fragment as we can. The radial head is actually more comminuted than we think, so we sacrifice the radial head and put a radial head replacement in. This radial head replacement from Synthes is very special because it's not cemented in, it's allowed to move loosely, it's just a spacer. Yeah, it's actually not fixed. All right. So, and can you see a little screw on the medial side there, just above the radial head?
Oh, yep.
Can you see that? So what we did was we used the radial head as a graft onto the coronoid because the coronoid was actually too comminuted and it lost the superior half of it. So we used the radial head to create a buttress. So you can see the screw here. That's to hold the radial head fragment onto the metaphyseal area to create to reconstruct a coronoid with a radial head fragment. This lady was doing reasonably good. She got extension of 30 degrees and flex of 120. She got pronation to about 90 degrees and supination to about 60 degrees. So she did really well after 3 months. And the graft has survived. So let's go back to the presentation to wrap this up because it's getting late now. So let's go down. So this is the lady in the clinic. And you can see she's about 120, not as good as the other side. Coronal supination was okay. And finally, let's go back to this, just for discussion purposes. Okay, good. Right. Share screen. There we go. All right. So in the worst case scenario, if none of your ligament reconstruction or fixation can work, you can use this device. This is called a IJS. It is actually available in Singapore via GN27 route. The company that sells this is the what's the company that sells Medatis? GenY. GenY sells this. So if you struggle and you think that this is going to be a potentially challenging case, you can put this internal external fixator in. It has a boom that goes into the capitulum and allows it works as an axis to allow the elbow to move. So this implant was supposed to hold it until all the ligament heals. This implant it was recommended to be removed when the elbow is stable, and at most at 2 years. So far, I've put it in about 4 or 5 patients in the UK. I've only taken 1 out. The rest of them were quite happy, even having this in, and the boom hasn't broken after 3 to 4 years. Right. So final one. Just open to all the panels and everyone. Right. You have a look at this fracture pattern. What do you think this is? Anand and Puya, I think this is a anterior medial facets and the tip of the coronoid fracture. It's consistent with a posterior lateral instability and with a posterior medial instability. What do you think? You can see the fracture fragment there. It involves part of the body, part of the tip, part of the anterior facet. So the radial head is intact. So this is a posterior medial instability. What would you guys do about this? Would you manage this conservatively, or would you bring the patients to theater? What are your parameters for managing this surgically or conservatively?
I mean, there is a role for conservative treatment of these difficult elbow injuries. It's not that all elbow fracture dislocations need to be operated surgically. So I think the criteria for would be that is the joint is congruent and if the joint is stable, because the
Yes.
most important part in the managing the elbow trauma is to make the joint stable and start mobilization.
Yes.
The
Indeed.
my criteria would be that can you start moving the joint within a week after the injury, and
Yes.
would the joint remain stable? So my decision to do surgical intervention or to operate non-surgically would depend on the stability of the joint when you start mobilizing it. So,
Yes.
so that is what would be my primary criteria to decide it. If I feel that the joint can be mobilized within the week of the injury and it remains stable, it doesn't need surgery. But if the joint is not stable and it's being mobilized, then yes, it need to be surgically stabilized.
Would you how long would you immobilize this? Because in 1 week's time the fragment was still displaced, right? Would you keep it a bit longer, like 2
No,
weeks to
I would not. I would not. So if the
Okay.
1 week time the fragment is still displaced, then I would definitely operate it, stabilize it, and start mobilizing. Because the key, for elbow joint for me is the mobilization, that you start mobilizing elbow as soon as possible.
Sure.
Yeah, Quen, I would jump in and say that I totally agree with that assessment. I think anything within 10 days, in fact, is rather painful. The patient actually can't cooperate. Obviously,
Yes.
at that point, you could also inject lignocaine into the joint and try and do examination under the radiographs, the
Yep.
image intensifier. But
Yeah.
it's usually a challenging proposition. Where
Yeah.
in about 10 days or so, they are much better off. The
Yeah.
hematoma is resolving, and that's where you
Yeah.
can ask the patient to straighten and see whether the patient will be able to load that elbow and not sublux. So
Sure.
I think that's what probably is going to drive the decision whether you need a buttress plate on sublime tubercle.
Yeah.
I
All
agree.
right.
And in my practice, as you know, Quen, so
Yeah.
I don't immobilize them. At the most, I give them a a poly sling or a collar and cuff for a week, because as you mentioned in your talk, if you give them a cast, that's going to possibly cause distraction, drop sign. If there is any underlying ligament injury, then reassess at 1 week, 10 days when they're less painful, and try and get them moving. If there's any evidence of displacement or concern, then at that point, I think it's reasonable to try and fix them.
Sure. So initially we watch and we will see if they have any signs of instability, whether the joint is congruent. So this initially was 3 cases presented by the Korean, and subsequently my friend or our friend Emilio and Antonio has published this paper. I think this paper has been repeatedly discussed in lots of forums. Antonio shows that most of the coronal fractures in fracture dislocation have no radiohead involvements. So meaning that it's most likely posterior medial type of injuries can be treated non-surgically with elbow immobilization. And of course, they agree with your management. Most of them get about 2 to 3 weeks of immobilizations, and after that they start moving them. And at any moment, if they shows signs of instability, they will go back in. So I think we all agree on the management of this, that if there's no sign, the essence of this is stability of the joint. If the joint is concentric and reduced, then there's a room for considering not to operate on this patient. Is that reasonable to say so?
Yes, I agree. Yeah, that's I would agree with that.
Yeah, exactly.
Yep, agree.
Okay, so I think it's 9:50 now. I appreciate very much both of your time in the West, where you were supposed to be dreaming away, especially Puya was supposed to enjoy his holiday in Malaga. Thank you very much for joining us today and give us your valuable opinion. And as I said, this presentation is up for you to grab from Jane if you need to. All right. Thank you very much, everyone, and I hope that this morning you get something out of this presentation. Any questions
Thanks,
for
Ben.
anyone? Yeah, thanks.
Thank you.
Thank you. All right. Okay, we'll draw it to a close.
Thanks, Kuan, for an excellent
Anand.
presentation.
Yeah,
No,
very
it
good. Have a
it was
seat
really
now.
lovely to see, your hard work as usual, that you have really done, spent a lot of time in making this presentation and making
Thank
it, so clear to the trainees there. I mean, uh, basically, the parting comment would be that in the elbow injuries, when somebody, for the training especially, when you see an X-ray, try to think beyond the X-ray. Try to think of soft tissues, because soft tissues are more important in the elbow than bony components there. So try
Yeah.
to work out that in this particular injury pattern, what soft tissues may have gone or may have remained intact. And
Yes.
as far as the imaging is concerned, the CT and MRI are not always required to
Yes.
work out the management. They're very rarely required. And
Yes.
the other thing is that when you take the patient to theater, EUA can be a very helpful diagnostic tool. So
Indeed.
you move the elbow under image intensifier and in supination and pronation. And sometimes you would see that the elbow is stable in supination, but you pronate the forearm and elbow
Yeah.
dislocates. And it's such
Yes.
a vital clue to know that
Yeah.
which have been important. So
Yes.
I always, prefer to do an EUA before actually putting the knife to the patient, to get more clue about the elbow injuries there. And the two basic things about the elbow injury: stabilize and mobilize.
Yes.
So don't compromise on that. And the worst thing which somebody can do is that you do a partial fixation and put the elbow in a plaster, which is the worst
Yes.
of both worlds. So
Yes.
if you are taking the patient to theater, do a full house and aim to do all fixations which is required, bony and soft tissues, and start mobilizing the elbow. And the MCL is really very rarely you need to repair the MCL, Once you have done on the lateral side, once you fix the radial head, then you do an EU again. And if the elbow is still unstable, then go for the MCL. In a very rarely you would require both the lateral and medial side to be repaired. And the Kuan showed some slides about the bony tunnels. And initially, I used suture anchors for putting the repairing the soft tissues and ligaments. But now I've moved to the bony tunnels as far as possible, because I feel bony tunnels are much more stronger and they are much more natural than the sutures. It's not easy. It's a bit fiddly and difficult. But if you can, get away with the bony tunnels, that is better than the suture anchors. So I think these are some of observations which I've learned throughout my process. Yeah.
Thank you very much for sharing this experience. I must say I've learned from you. So what I did was pretty similar.
We both have learned from each other.
So what I did was pretty similar to what you say. And yes, I used the bony tunnel. The only thing that I find slightly different coming to Singapore is that the bone quality is not very good, and sometimes the cortex could be as thin as an eggshell. So putting a transosseous tunnel sometimes risks cracking it through. And we also don't have a synthetic ligament here. So whilst the synthetic ligament can fit through a 2 millimeter drill holes, here either you use allograft or autograft, or you use a BioBrace, which is not very forgiving. So it's not very malleable. You can't push it through a 3 millimeter drill holes. To get it ready to slide a 3.5 millimeter drill holes, which is quite big for a small Asian. So there are potential challenges. So in patients with good bone quality, I would use a bone tunnel. But for patients who doesn't have very good bone quality, I would use anchors or even a suture button just to get bicortical.
Yeah, I agree. Yeah.
Anything you want to add, Puya?
No, all I wanted to say is that was a very, very, very comprehensive talk that you gave at the start. Great evidence, lots of good papers, things that we're all familiar with, and obviously, we've worked together for a few years, so I've seen and I've learned from some of your techniques, which I also use in my clinical practice, especially synthetic ligaments for reconstruction of the medial and lateral collateral ligaments. So I think that's a very useful tip for everyone to be aware of when thinking about stabilizing elbows. So I thought that was very, very good.
Thank you very much for your kind words. I realized that you actually bring your suit or your shirt and your tie.
I thought this was a talk, so I thought I was supposed to wear a tie. Maybe I'm overdressed. I don't know.
I'm wearing a polo shirt. Okay. All right. Well, hopefully we can invite both of you to Singapore to see some of the activities here. We look forward to do more activities with you guys. Sorry.
Yeah.
Sounds good.
Okay. Thanks very much. Thanks, Kuan, for your hard work, and I'm sure the trainees have learned a lot, and they should continue to learn from you. I mean, you have such a vast knowledge, experience, and a lot you can give to the trainees there in Singapore.
Thank you very much. All right, guys. Good night. Have a good day.
Night.
Let's catch up with you soon.
Bye.
Bye-bye.
Bye. Bye.
Bye.